Thanks, Ocean, for the introduction. As you said, we will show you the job we did to make the SNDS, the French medico-administrative database, into an interoperable database. So what is exactly the SNDS? You heard this word several times today, but maybe some of you doesn't know this database. The SNDS, it's a medico-administrative database, and it contains data from French population since 2006. Inside, you can find some information for outpatient visits, some information for hospitalization and cause of death. As you can see, the structure is very complex on the schema on the left, and inside you have like more than 180 tables and more than 4,500 variables. So it's the structure is very complex, and it's very difficult to do research on it when you are a new user of this database. To give you some number, inside the SNDS, each year you can have 1.2 billion of claims. Each year you have 11 million of hospital visits. So in total, since 2006, we have 250 terabytes of data. So it's very complex to use this data, and we have the complex structure. And in France, we have also a specific terminology, since we have more than 40,000 French vocabulary, because we have our one system to describe all the procedures, the drug, the diagnosis, etc. So we are working to transform the SNDS into an OMOP common database since 2 years. And for that, we have 3 main steps to transform the SNDS. The first one is to establish a correspondence between the fields, so all the variables and the terminology of the 2 formats. After, you have to write all the scripts to switch from one format to another. And finally, you have to check the quality when you transform the SNDS into a OMOP common data model. And today, Cécile will present you some result of the quality of the transformation. Several people were involved inside the project, so we worked with some data engineers, some data scientists, of course, some SNDS experts, because we didn't know this database before we started the project, so we needed to learn how to use it. And we are also working with some medical interns, because we don't have the knowledge for all the medical information. And we are also talking with BPE and APHP, which will be presenting just after this presentation. And the objective is to harmonize all the transformation rule in France between the Bordeaux pharmacoepidemiology platform and APHP.
As Erika said before, transforming a database into the OMOP CDM format is an iterative process. First, we have to write the rules in natural languages, and once the rules are written, we have to check with database experts to be sure that we didn't misunderstand the data and there are no misinterpretation of it. And we have also to check with Eden, and we had once a week a meeting with them to perform that. And so they explain us how the fields are used, which country use it, and to harmonize with the other partners. Once both experts and Eden validated our rules, we can code it in SQL. And afterwards, there's a final validation of the table with the data quality tools of Odyssey. If it is validated, then we can, the work is finished, well, even if it's never really finished. And if not, we have to come back to the first step of writing the rules in natural language.
So Cécile presents you the way we did to write the script to transform the SNDS into an OMOP database. And after, we have also a huge work to do the mapping between all the terminology. So as I told you, in France, we have more than 4,000 terminology. The more famous terminology is the CCAM code to describe all the procedure performed in the hospital. So we have more than 800 CCAM codes. So what we decided to do the mapping between CCAM and SNOMED City, which is the international terminology accepted inside the OMOP Common Data Model database, we decided to map all the 80% of the most frequent codes, and for the other codes, we decided to work only on the chapter. After, we did exactly the same for the CSAR code, which are the codes for rehabilitation. So we mapped the 80% of the frequent codes, and after we worked on the chapter level. For NABM, for the biological code, we have only less than 1,000 codes, so we decided to map every code onto SNOMED city codes. For LPP, it's codes which are used for device. So in France, we have many details inside the LPP. So it was like impossible to transcribe all these details inside the SNOMED city terminology. So we decided only to work on the chapter level. And as Axel asked before for the presentation, if we have a mapping between CIP UCD codes, so the code used for drugs, onto RxNOM, so the code used for drugs in the OMOP common data model database, it's a job we will need to do because for now, nothing was done. For the process, the Health Data Hub coordinates all the process of the mapping terminology. We worked with medical interns, who has the knowledge of the vocabulary. So what we did is one intern do a first mapping, and after another intern review the mapping we did. We also worked with the platform Bordeaux Pharmacoepi, and they help us to design and to follow all the project. And finally, of course, we worked with Odyssey and with Michael, which you met him earlier. And I would like to thank all the interns who worked on this project. So Alexandre Kittic, Nicolas Kittic, Sarah Tunon de Lara, Raphaël Rie et François Bourcard.
So on this presentation, we would like to focus on data quality checks. So to perform that, we will give an example of a run on an EMA project on glucocorticoids. So in 2020, EMA entrusted an observational study to IQVIA on glucocorticoids and COVID. 7 European countries were involved in this project, and they were in charge of conducting the study on their national data. And in France, PEL Lyon was chosen as the French reference. So after the relevant data was retrieved from the SNDS, the AGH was in charge of transforming it into the OMOP CDM format. So in the end, we had a cohort of 300,000 patients, which represents more than 200 gigabytes of data. And as usual for the SNDS, more than 180 tables and more than 4,000 of variables. After the transformation, the data was only 30 gigabytes and only 37 tables, which is one of the advantages of transforming the data into OMOP CDM. So first, data quality checks. These are general results on the first checks with one Odyssey data quality tool, which is called Data Quality Dashboard. It is divided into 3 main subjects: plausibility, conformance, and completeness. Regarding conformance, it's about the relational schema to be sure that it is conform with the OMOP CDM format. For instance, if the primary keys or foreign keys are respected, and if the types are good. And regarding completeness, a part of it is about vocabularies mapping. If the source vocabularies are mapped onto standard vocabularies, and if the mandatory fields are filled in. About plausibility, we would like first to moderate the result, but I will do that later, I'm sorry. So plausibility is about medical and temporal validity. It checks if, for instance, if end dates are after a start date, and there are also medical validity with checks such as how many women have prostate cancer. I said that I wanted to moderate this very good results because there are many results on measurements, and measurements are not available in the SNDS since we don't have the measurement results. For instance, we know if someone had a PCR for COVID, but we don't know if it was positive or negative. And in the data quality checks, missing is equivalent to passed. So that's why we have such high numbers, and it wouldn't probably be the same if missing was failed. A few results with Achilles, another Odyssey quality tool, which allows us to visualize our data. can be very difficult with the SNDS. First, a few general results with population by gender, for instance. We have a 50-50 distribution, which matches what we expected. And the age at first observation. Here we can see that the people in the cohort are quite aged. That's probably because they are people hospitalized for COVID. And as we know, those people were ager than the population. And the data density by domain is the number of records per person. A domain is, in OMOP CDM, a visit. It means when you go to the hospital or when you go to the doctor or the pharmacist, etc. Death, drug exposure, measurement, condition, observation, etc. So it's the number of records in the database during the duration of the observation. And for the 3 next slides, we'd like to focus on different codes because Achilles allows us to visualize a distribution for different standard codes. So this first slide is about one COVID code, and I would like to highlight this fact. It doesn't mean that only 15,000 persons in the cohort have COVID. It only means that 50,000 persons have this code to code COVID in the database. So on this slide, we can see that we can visualize the 2 waves of the pandemic. On the contrary, this slide is not about to code. This code is not for people for which we are sure that they have COVID, but for people with a suspicion of COVID. So it's a bit higher than the prevalence is a bit higher than before. And we can also see that for the first wave of the pandemic, contrary to what happened before, it is really higher than the second wave spike, and showing that we didn't have the tests weren't available during the first wave. And to end this presentation about data quality checks, an amusing result on dental scaling and polishing code. During the first lockdown, of course, it fell to 0 because dentists were closed. And during summer holidays, French people have other things to do. Thank you very much.
Thank you very much, Lorien and Cécile.
So to conclude, I hope now you are convinced that the SNDS is a very complex database and that we needed to have an interoperable database in order to facilitate the reuse for perform some research project. And if we use the normal SNDS, it's very difficult to provide some statistic, as Cécile showed you, for the quality check, and it's very difficult to do some data visualization on it. With the SNDS into an OMOP common data model, we have like a centralized patient healthcare database. And now we are working on the documentation, since we want to publish in open source all the script we did to transform the SNDS into this OMOP CDM database. And normally it should be easier to do some research on it, since we can have some script shared between all the researchers, and we can use some reusable algorithm from the community. So thanks to all the persons involved in this project and to you for your attention.
Thank you. Thank you very much for this very bright presentation to both of you. I think we already have 1 or 2 questions from the chat. We can also take one from the room, but I'll start here. Is the ETL self-developed by SQL, and is there any use of ETL tools such as SSIS or Talent Open Studio? Do you have any?
On technical terms, we use the DBT, Data Build Tool, which is based on SQL and which can run also on Apache Spark servers.
Thank you. I'm not going to pretend I understood all of that. Is there any questions? Are there any questions from the room here?
Thank you again for that presentation. I just have a question. So if you're doing that kind of mapping, at some point, did you have any doubt about the code in OMOP that you should use? And if yes, how did you solve that? And sorry for the question. I know it's not easy, that one.
No, it's not an easy one. So to be honest, we finished the first mapping of terminology since only a few days, like 1 month. So we are just now checking all the quality Cécile showed you with all the distribution, but we didn't get inside to understand really if it's coherent or not, the mapping we did. So after we will have like a very huge work to do to just be sure all the job we did is correct and can be reused by someone else.
Can you please speak in the mic so that people remotely can hear your question too? Thank you.
Sorry, I guess my question was more related to the moment you're doing the mapping, you know, when you are choosing the code.
We gave the intern a very strict procedure.
Okay.
We changed during the process because we started this mapping in July. So of course, at the beginning, the procedure was not perfect because we didn't thought about all the problem we can have during the mapping. So we did some improvement, but we gave the intern some procedure to respect and because I wanted to have like an harmonized process for the mapping, but of course, 5 interns worked on it. So of course, they didn't do exactly the same thing.
Do we have time for one more question? Okay, so there was this question from the audience. Apart from allowing the running of network studies, can you expand on the other advantages of mapping to OMOP for the data hosting institution? And do these advantages alone justify the effort involved in the mapping?
You want to answer, Peter?
I think a couple of things to mention there. So first of all, the tools that have been developed, and you haven't seen all the tools yet, are also very useful within the organization themselves. So even the quality control process that has been enforced creates a lot of insights in your own data and improves that data as well over time, I would say. What we don't want to see is that many organizations are building the same tools. And so all the visualization tools, and you just showed 2 slides of Achilles, but there are many other nice visualizations of your data. I know in our own organization at Erasmus, we, for example, would like to build dashboards. But why do we start from scratch again to build dashboards on our source data? If we're now moving to OMO, we're just going to reuse the things that we have built there and see what we can do with that and move onward. I think it's not only for participating in international studies, but also within your own country, within between organizations is very useful, I would say.
And as we saw with the data quality checks, those statistics are quite hard to have on an entire SNDS because the information is spread between multiple tables, and now it's just on one table and easier to look at that. If the mapping is good.
Maybe to put things back into context for the people remotely, Peter Reinbeck is contributing to answer.
Yeah, so and indeed also reusing analytical tools that have been developed by others. So answering questions like drug utilization or so, you don't want to start from scratch building those analytical pipelines again. You want to build on something that's been developed by others, and I think that's a big opportunity also for your internal studies. I really hope also in our own organization that we can run and answer questions faster by having our own data in Erasmus also on the OMO Common Data Model.